Hello, I'm very happy to be with you. I'm going to present to you one of my latest lectures. It's going to be about a topic that's very important in endodontics, and it is CBCT usage in endodontics. Now we're going to talk about diagnosis of periapical lesions because we see periapical lesions often, and these lesions are very important to be seen in three-dimensionally so that we understand the extent of the problem. I'm Professor Hussain Al-Huwaizi. I'm from the College of Dentistry, University of Baghdad, and the Iraqi Dental Association, and member in many societies of endodontology in the world. Before I start any lecture, I go to the literature and see, is this topic very important or not? So I just punched in cone beam computer tomography, and you can see the graph of the number of researches being done regarding CBCT. So it's really a very important topic, the hotspot in endodontics. So why 3D? Why three-dimensional? Because if it's a 2D, we are going to talk about the height and length. But if it's a 3D, we add the width, and really this is quite important. This is a 2D X-ray. It shows clearly two-dimensionally, but what I really want is that I see the three-dimensional. So I want to see the axial plane, the coronal plane, and the sagittal plane. And this is a picture from the CBCT that we see. First of all, three-dimensional, animated, and then the three planes. So I can get a clear picture of my problem. The advantages of CBCT, first of all, it's a rapid scan time, beam limitation, image accuracy, reduction in radiation dose when compared with medical CT, and it is quite safe. It's important that we choose our field of vision because this gives me a reduction in the radiation given to the patient, and at the same time I can get a clearer picture to the specific area that I want. And I use normally the smallest, which is 4x4, which shows me the tooth that I want and the picture of the area. This is the position of the patient. He has to stand upright. Now, when I use CBCT, I really need this tool to help me in many areas in dentistry. For example, diagnosis. This was a case that was presented to me. The patient brought his panorama X-ray, OPG, and I can see that the maxillary right lateral incisor has got some kind of periapical lesion. Of course, I found, or it was more of a dense indenti in the tooth. So really, I was skeptical about is this radiolucency a lesion or what? Because I've got another lesion here and here and here. So I took a CBCT and I found this is not dense indenti. This is a large cingulum, which can be seen here, a huge cingulum really. In the axial plane, as we go up, you can see that we don't have a dense indenti, and we've got the calcification in the canine. As we go up epically, I didn't see any lesion. To the end, and there is no lesion. And the coronal shows it clearly that there is no lesion. So CBCT saved this tooth from unnecessary treatment. Lateral canals. These lateral canals really may be associated with laterally positioned lesions, and they are the prevalence of the lateral canals is around about 45–49%. And we can see a lot of research using CBCT that found the lateral canals to be present in much more than we expected, around about 85%. And it's stated here that the higher resolution mode should be chosen to demonstrate the root canal system and partially laterally lateral canals. Of course, when we used to take an X-ray, we may see, for example, these apical deltas or lateral canals, but we see them when they are mesially and distally, but buccally and lingually, we cannot see them. As this X-ray shows, I've got a lateral canal that is buccally positioned, and with the CBCT, I can see it. Another case here, extrusion of sealer through a lateral canal palatally in upper 6, and associated with a laterally positioned lesion. This is another laterally positioned lesion, the maxillary premolar, and you can see that the extrusion through a lateral canal. Another picture of lateral canals. This is a huge lesion associated with the mesial and distal roots of a mandibular molar, and you can see the extrusion through a lateral canal. So this lateral canal may be associated with this huge lesion. So it's imperative that we treat this lateral canal in order to have a good and you can see this huge lesion associated with the whole tooth, and you can see that the mesial root has got a lateral canal, and with this treatment, I hope that we can get healing. This is another lateral canal with the palatal canal of an upper six, and this lateral canal is positioned palatally, so it is really impossible to see it by a 2D X-ray. So it's important here that we take an CBCT to see this lesion. Extensive lesions. It is stated here that lateral lesions, the prevalence is around about 0 to 0.9%. Apical root resorptions is quite low, 0 to 3%, and periapical lesions is from 4 to 13%. That means that periapical lesions are very often, and they have to be diagnosed very well, and we may need CBCT for this diagnosis. For example, such a case, a maxillary first molar was presented to me, and this not very clear picture made me feel not very happy. I wanted to analyze the area before I start my treatment, and I can see now by CBCT you can see the resorption of bone of the mesial buccal root is very evident here, and by the axial you can see the palatal root here has got a big lesion, and the mesial buccal, the cortical plate is destroyed. So in this case, it is very important to get this picture because this picture might be not very indicated for endodontics. Another picture with a lateral incisor, again, and not a clear picture. And with the CBCT, you can see the huge lesion associated with this tooth. Another X-ray. And maxillary molar with, again, not a clear picture, and you can see here very clearly the amount of destruction of bone around the two buccal roots of this maxillary molar. This is another case whereby there's some kind of blurriness. The lamina dura is discontinued in this area, and when I took a CBCT, you can see the destruction of the cortical plate associated with the mesial-buccal root. This is a mandibular molar with a large carious lesion distally. Periapically doesn't show anything. It's a very clear picture. Lamina dura is very nice, and really it's quite indicated for endodontic treatment. But when we take a CBCT, you can imagine, you can see the destruction in the bone buccally. It included even the bifurcation area, and in the axial view, you can see it very clearly here. So this picture is not like this picture. Endodontic surgery. This was a very interesting case whereby I had a person sent to me after doing surgery, removal of a keratocyst. It's a very huge lesion, and it made 5 teeth non-vital. I did the endo treatment to them using the apex locator because, in such cases, this lesion makes a lot of apical resorption. So you wouldn't see the apical foramen or the extrusion of the cemented dentinal junction as a normal. It's in the normal position. So it's imperative to use the apex locator to get our area of termination of my endo treatment. After 18 months, you can see the healing, which was quite nice, but it made me feel not very happy. I wanted to see is this a full recovery of the mandible or what? So I took a CBCT, and I saw that healing happened, but there was some kind of crater that stayed in the mandible of the tooth. Of course, there's good healing, but it needed more surgical intervention of maybe bone grafting so after the healing after endodontic treatment, I sent the patient back to my to the surgeon and for consultation. This is a case of root canal sclerosis. Of course, previously when we have a patient coming with trauma to central incisors, and you see that the root canal is not present, we used to drill through the tooth, hoping that we can find the root canal. But nowadays, with the CBCT, we don't need to do that. All we do is that we take the CBCT and see clearly is the root canal present or not. So I might, if I've got a lesion associated with this tooth, I might send the patient to the surgeon. You can see the two lesions associated. So I can't help him endodontically. I can help him surgically. At the end of the lecture, I am very happy to invite you to the Iraqi Endodontic Society. We've got more than 9,200 members. We share cases, and we will be very happy to have you with us. Anyone interested in difficult cases? I've got 9 of my difficult cases were published by Endodontic Practice UK in 2020, and it is shown here clearly. You can enter and see. And I've got a YouTube channel called Simplifying Endodontics with Hussain Al-Huwaizi. You are more than welcome to see them. They're related to different topics in endodontics. And thank you very much.